For our next presentation, we are joined by Dr. Saidinejad. Mo is the professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA and director of pediatric emergency medicine at UCLA. He also serves as the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harbor UCLA. He serves as director of patient experience at Harbor UCLA Medical Center and the Department of Emergency Medicine. Mo has been involved in multiple national organizations, including being the past chair of the Pediatric Emergency Medicine Committee at ACEP, chair of the PEM interest group at SAEM, and is a current member of the AAP COPEM. He is also one of the domain leads for the HRSA-funded knowledge management domain of the EMS for Children Innovation and Improvement Center, or EIIC, and the Knowledge, Education, and Communication Core of the Pediatric Pandemic Network, which is also funded by HRSA. Dr. Saidinejad has his research and advocacy concentration in pediatric mental health in the emergency department, including ED-based interventions, and has led the development of the pediatric education and advocacy kits for suicide and agitation for the EIIC. He is the lead author of the upcoming AAP, ACEP, and ENA joint policy statement and technical paper on the role of emergency medicine clinicians and the assessment and treatment of children with acute medical and behavioral presentations. His presentation, Mental and Behavioral Health Presentations in the ED, What to Do, will cover the objectives seen on the screen. We're grateful to partner with Children's Minnesota to offer 4 AMA PRA Category 1 credits for physicians and 4 ANCC nursing contact hours. Please take a moment to review additional accreditation information from Children's Minnesota. Next, we have our standard disclaimers and confidentiality protection statement to share from Children's Minnesota. Please ask us if you have any questions about these disclaimers and/or confidentiality protections. Lastly, we have our standard faculty disclosure announcement. Our planning committee and presenters have no relevant financial relationships to disclose. Please ask us if you have any questions about these disclaimers, disclosures, and/or accreditation information. Thank you very much. Mo, you can take it away.
All right, thank you very much, and thanks for that really kind introduction. Really appreciate all of you guys giving your late afternoon on a Thursday to be part of this symposium. It's a great honor to be here and present to you guys. As mentioned, I am a professor of pediatric emergency medicine at Harbor UCLA, and I have many, many hats that I'm wearing, but today I'm here talking to you a little bit about how the pediatric mental and behavioral health affects us in the emergency department and some of the solutions that we have come to use in order to help all of those clinicians who take care of ill and injured children with mental and behavioral health problems. As mentioned, I don't have any financial disclosures. I do have funding by HRSA, so I always have to add this acknowledgement that I am supported by a U07MC 37471 grant that totals $2.5 million. All of that is coming from governmental agencies and nothing from non-governmental sources. Everything I say would reflect my own opinions and not necessarily consider an endorsement by HRSA, the Health and Human Services, or the US government. So today I will basically give you a little bit of background and introduction about the problem at hand, talk a little bit about how pediatric mental health works within the ED environment, talk a little bit about how the EMS for Children developed initiatives, as mentioned before, the resources we developed through the knowledge management domain, as well as the EISC quality improvement collaboratives that many of you guys are familiar with. And I'm going to wrap up with this joint policy statement and technical report, which as of now, it's actually published, it's out there. So I can share that work with you near the end of this conversation. So let's just start with the introduction and background. Most important factors that I deal with on a daily basis is the fact that we've had a significant increase in the number of presentations of mental and behavioral health to the ED over the last decade. And that says a lot. We know that at least 1 in 5 children under the age of 18 struggle with something that can be considered a diagnosable mental health problem. That is 20% of all of our children. At the same time that the scope of the problem is so great, we are also facing with the ongoing shortage of mental health care system to develop the resources needed to care for these children. So we're having a reduced number of child social workers, child psychiatrists, clinical psychologists, and any professional who can care for mental and behavioral health emergencies. As a result of this, any patient that is seen in our ED environment who requires a follow-up will have to wait anywhere around 6 weeks or so to get an appointment with a psychiatrist. And there's plenty of literature that support that the most important thing is timely follow-up. And there are studies that show the most important follow-up is within 7 days of the ED visit. So as you can see, we don't have the capacity to care for this problem at the level that we need to. And as a result of that, more than half of the children are not receiving the mental health care services that they need. But beyond the fact that there is this overall number of children versus number of resources, there's also that element of disproportional impact on certain groups. So not all children are affected equally. And this is something for us in the emergency department to be aware of and know, because we can then decide who is at a higher risk and needs to get more promptly screened. In the emergency department, sometimes we don't have the ability to universally screen everybody, but if we're going to go with targeted screening, knowing the patient's background should be one of the elements that help you raise your concern about the potential of the mental health issue. And finally, the other piece of this is that from the moment that the child exhibits any little subtle hint that they may be having some mental behavioral health issues until somebody gets them diagnosed can take up to 10 years. And that's a long time. So anyway, because of all of these issues, there is a lot of visits to the emergency department because we are essentially the safety net and a de facto referral place for all of these children who've been identified as potentially needing mental behavioral health services. And obviously in the emergency department, we don't have the staffing, we don't have the resources or the space to care for this problem. So it becomes a problem of difficult proportions for us. So as mentioned, the first problem is that more children are coming in with this complaint. They're coming in younger, and they're coming in with more complicated history. So every day, the problem is escalating from the standpoint of numbers and complexity. And the reason is essentially that there is a lot more hypervigilance. People are more aware about mental health. There's more on the TV, there's more on social media about it. So more children are being identified and referred for mental health services. There's also the potential of vivid depiction of violence and things like that that can cause the complicated thought process of suicidality or agitation to be exacerbated quite as much as it, a lot more than it should be. And at the same time, we're losing mental health professionals. But referrals coming from schools, they're coming from homes, they're coming from pediatric offices, they're coming from urgent care centers and law enforcement. And that is essentially what the bottleneck is for us in the emergency department. This slide is basically showing you that before even COVID started, the number of pediatric mental health visits was increasing, and children were affected a lot more than adults were in terms of this rate of increase. And we also noticed that not only that the rate was not going down, but there was a recent study at Children's Hospital Los Angeles that was conducted actually up just before COVID started. COVID started in mid-March or so of 2020. This study ended February 29th of 2020, that each year during October 2015 and 2020, the mental health visit to their emergency department increased by 8%. But the other emergency department visits were only increasing by about 1.5%. So that means if you look at your emergency department, there's a higher concentration and proportion of mental health compared to the other patients that you had in your ED. And all of these patients that came for a mental health visit, 13.2% of them actually returned for a 6-month visit. And we do have studies that show that if you don't get that follow-up with a psychiatrist within 7 days of that ER visit, you are much more likely to show up to the ED again. So this rate of revisit goes in with those proportion of patients that were not getting the follow-ups that they needed. This shows you the prevalence of mental health during COVID. And as you can see, right when COVID hit, for a little while, there was very little visits because there was that stay-at-home orders and there was no schools, so children were not really checking in with other kids. And we know that during school year, there's a lot more prevalence of mental health than during summer months. So all of those kind of tied into how in the very, very beginning of COVID, there wasn't really a lot of mental health visits. But then now, as you can see, the numbers have increased to beyond what the pre-pandemic numbers were. And the little dips are during holidays and school off period. So it makes perfect sense that when kids are around other kids, they end up getting triggered for their mental behavioral health problems and things escalate. This led to the call to action that, as many of you guys know, started out with the HRSA, our funder, put together this 104-page PDF document that is entitled The Critical Crossroads, Pediatric Mental Health Care in the Emergency Department. It really does a great blueprint of how to care for pediatric patients with different mental health problems. And at this the AAP, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association published this paper in 2021 in AAP News declaring pediatric mental health an emergency and national emergency, paving the road for several organizations to write a letter to the Biden administration asking for better legislation, better financial support for pediatric mental health. So as I mentioned, the second challenge, besides the numbers increasing and the complexity increasing, is that there's a decrease in the number of professionals who are licensed to care for pediatric mental health. This is a map of the country looking at the entire psychiatry. All of these little areas of gray that you see, those are counties within the United States where 0 being gray, meaning there's not one single mental health professional on staff. And overall in the United States, more than 55% of all of the counties in the United States do not have a single psychiatrist. So this is what the problem is. This is the disparity. This is where you live. If you live, for example, in the Pacific Coast, if you live in the Northeast, you have better access to psychiatrists than if you live in majority of the middle of the country. If you take the same map, look at it as a child and adolescent psychiatry, it looks even more gloomy. A larger proportion of counties don't have any mental health professional. So that is just a matter of supply and demand. This map that was developed by the American Academy of Child and Adolescent Psychiatry, and the QR code for it is here. You can actually go and look at each state specifically, shows that on average, there are about 14 child and adolescent psychiatrists for every 100,000 patients. So if you look at it, there's 74 million children under 18 in the United States, and there's about 10,000 child and adolescent psychiatrists. And if you look at this little bar graph in the bottom, it shows you by state. So if you're in District of Columbia, the green one, you're doing better. There's 65 for 100,000. But if you're in Wyoming, there's only 4 for 100,000. So there's also that geographic disparity as well. This map shows you everything that's the dark blue is shortage area. So essentially the entire country is a mental health provider shortage area. The map on the upper right shows you where the greatest number of children with mental and behavioral health problems are. The darker it is, the more prevalent. And if you can see, this map and the map below it don't really jive, because the map below has all of the states in the dark blue, showing that these are places where more than 50% of the children are not getting the psychiatric care that they need. So there's that element of disparity as well. And then there's challenge number 3. The problem is increasing, not only that children are being diagnosed more, but this study in 2021 showed that for the children between 5 and 17 years old, in the last 12 months preceding the study, about 8% of these children actually were taking medications, and 11.5% of them receiving counseling and active therapy. So that's a huge proportion of patients who are actually under care. And this basically shows you the same numbers that you are more likely to take medications if you are older age group, and you are also there's another graph in here, I didn't have that in there, but it shows that if you're boys, you're more likely to be taking medication or getting therapy compared to girls. The challenge number 4 is the disparities I was talking about again. Yeah, sorry, this is the map I was going to refer to. This shows you that you are a higher likelihood to be treated for any mental health care if you're boys. You are more likely to take medications, but you're less likely to receive counseling or therapy if you're a boy. So girls were getting more therapy sessions, boys were getting more medication. So there's a disparity there as well. If you look at also race and ethnicity, you realize that you are much more likely to have a prevalence of mental behavioral health if you are non-Hispanic white. Second group was non-Hispanic black. You're less likely to have that if you're Asian. So there was a disparity in this. However, a sub-study of this looking at 5 to 11-year-olds, meaning a subset of the 5 to 17, black males were much more likely than white males to be having a complaint related to mental health, especially suicidality. So that was a disparity there that's in the smaller of this section of the age group. This again showing you the same I just mentioned. This is, sorry, going a little bit faster than I like. So for boys with suicidality, boys who are black were 2 times more likely compared to white peers to have suicidality issue if they're under 13. And not only that, but the suicide becomes more of a leading cause of death in that age group. So go from the 5th leading cause to now the 3rd leading cause. And also the percentage of like high school students who have considered suicide, made a suicide plan, or attempted suicide has also increased year over year from 2008 to 2018. This also looks at rurality and urbanicity. So you're more likely to have a mental behavioral health presentation if you are in a non-metropolitan or a rural, more of a suburban area, less likely if you are metropolitan. Again, these numbers have variation, but there is that disparity, not just, as we said, based on your gender, race, but also urbanicity. So that's another layer of disparity that we experience. Finally, the biggest of the issues is that based on your gender identity, there are more risk factors associated with identifying yourself as a LGBTQ+. For example, an LGBTQ+ high school student was 5 times more likely to have considered suicide than somebody who did not identify themselves as a LGBTQ. This is pretty straightforward. We know this by children who are in foster care, who are in group homes. There are children who are living in families with limited English proficiency, incarcerated youth, children who are autistic or have any other neurodivergence conditions are more at risk. Children who are living with somebody in the house who's a victim of violence or themselves are a victim of violence. Children who have family history of mental health illness, and children who are bullying. And I mention these is because when we have challenge in the ED with our volumes, we can't screen everybody. We need to kind of screen targeted. These are some of the factors to consider as risk factors to have somebody be getting at least a targeted screening if you're not doing universal screening. But these are all risk factors that increases the likelihood of having a mental health complaint. Oh, and by the way, before I move on, I want to say one challenge is that when you do universal screening, you actually find those who screen positive for suicidality that didn't even come for suicidality. So you're catching patients that weren't otherwise going to be caught. So this is, again, a value of doing universal screening, because half of your patients who are positive did not come in with a suicidal complaint, and that's kind of scary. Again, a little bit more on suicide. This is information you guys already pretty much know. Second leading cause of death now between 10 to 24 years of age. The rate increased by about 50% between 2000 and 2021. ED visits 3 times that of the equivalent adults. So young children are 3 times more likely than young adults. Actually, 63-year-old being a young adult. It's interesting because that gives me hope. But that is 3 times as likely than adults. Girls and young women, twice the likelihood as boys and young men. We talked about this already. The LGBTQ is 5 times more likely. Alaska Natives, American Indians, Black youth, and those who are in the heavily populated, underserved urban, as well as those in the rural areas, are more at risk. And this is the link for the CDC data from where all this came from. The scariest thing I could tell you about all of this is that not only that this problem is increasing in complexity, but now we're starting to see this younger and younger age group. So believe it or not, now suicide is creeping up into the top 10 causes of death among children 5 to 9 years old. And this is really scary because in the ED, I see these young children coming in at 5 or 6 with suicidal ideation. And I wonder if they even have a concept of what it means to be dead, what it means to not live. But this is increasing a lot. A lot of children are being referred because they drew a picture of somebody hanging, or they said they wish to be dead. And our job in the ED to try to figure out which of these was just a spur of the moment comment and which one of them is actually at high risk. So this is why we need our mental health professionals to help us sort this out, since we ED physicians aren't really in a position to be able to assess these. So moving on to the next. So there are a lot of strategies that are being discussed. So what can we do to make it easier for us to care for these patients in the ED? And a lot of these are pipe dreams. You should increase your resources. Well, we have all the resources we have. I work at a county hospital. The resources are basically county items. If there's no more items, we can't hire anybody else. If one of our items leaves and nobody's replacing them for whatever reason, then that's it. I can't knock down walls and increase space. That is something that is asked of us to do, but it's just very hard to do. Talking about training of our staff, we're already asking our staff to do a lot. There's a lot of competencies that they have to keep up with. And for one thing, when I will tell you about the policy statement that we published, one of our partners was American College of Emergency Physicians, and they had a strenuous objection to us including any language in there that says we need to increase training. So that we basically had to not do. And so we took out training is not an issue, space and resources are. So you can't, it's a very political thing to say increase training of your staff on mental behavioral health, because the perception would be, okay, so you're saying that instead of hiring professionals, you're just going to make the ED people do all the work. And that's not going to go very well. Increasing the number of mental health professionals, that's just a pipeline issue. There aren't enough mental health professionals, especially those who are specializing in children. You can't manufacture them, and we are too far away from artificial intelligence being able to do this, and God forbid the day where they are going to get involved. But right now, that's not an easy thing to do either. And the last thing is, well, why don't we just decrease the referrals to the ED, have them go somewhere else? Well, where do they go? We are the safety net because they have nowhere else to go. Technically, there are places, there are crisis centers and things like that, that if we knew more about, some of the patients could be shuttled to, and some states have really good programs in having directly referred to a crisis center. But a county as big as Los Angeles, this is just not practical. The ambulance drivers are going to bring them to all of the pediatric, we'll call them Emergency Department Approved for Pediatrics, EDAP, in LA County. All mental health patients are supposed to be brought to an EDAP hospital, and there's 33 of them in the county of Los Angeles, so that's where they end up. And so all of these things up here are wishful thinking. They aren't really easy to implement. So we can't solve the problem with any of these obvious options. So let me take a couple of minutes talking a little bit about our new mental health policies that we did. So this paper was published in October. It's a lot of hard work by at least 30 people working 3 years, representing 3 major organizations: the American Academy of Pediatrics, American College of Emergency Physicians, and Emergency Nurses Association. This policy statement also came with a technical report, which has a little bit more in depth about the state of the problem and some strategies about how we can actually regionalize the care that we have a system where a psychiatrist can do consults in multiple settings, more than one hospital. Maybe they do it through telehealth and things like that. So those recommendations are coming in with the technical report, giving a little bit more detail about how we're going to accomplish those. The QR code you see up here takes you directly to the AAP's publication of this technical report. So this policy statement was very interesting because it was needed. Back in 2018, we looked at all of the policy statements around mental health that were in existence. AAP had their own, ACEP had their own, and ENA had their own. But all of them had a lot of language in there were already outdated because this issue of mental health burden and capacity is moving really fast. So already something from 2018 would have been 2-3 years old. So we set a goal to do it right and do a joint publication with all of these 3 organizations and make specific consideration. One was that there wasn't anything in those policy statements that give guidance about how general EDs in rural communities are supposed to manage this. And we know the majority of our patients, more than 80 to 90% of all mental health complaints among children, do not go to a children's hospital. They all go to these community EDs. And we had really no specific sense of what a smaller, low-resource place was going to do. So we made sure that we had elements of that in our policy statement. The second element was that we wanted to make sure that not just for the emergency department, because the problem may end up in the emergency department, but it doesn't start in the emergency department. It starts in the home, it starts in the school, it starts in the street, it starts at the police station, it starts elsewhere in the primary care doctor's office. So we wanted to make sure we have the consideration of the entire continuum, including what paramedics were supposed to do when they encounter a case of pediatric mental health. Also, what happens when the patient is finally discharged from the ER? What about the safety planning? What about emergency department aftercare? And the third element was that we wanted to make sure same language, one verbiage for all 3 organizations, which is why it took 3 years. Because agreement between those organizations wasn't an easy thing to accomplish. So that's why it took so many drafts back and forth. And then finally, the biggest element was that we had a one-size-fits-all. We did not say enough about how equity and diversity in access, and not just equity and diversity in the patients, but equity and diversity in access to mental health services was a factor. Some places had all the resources they need and they could manage all the capacity, but other places had no resources, no capabilities. So considerations such as, if you're a rural ED in the state of Washington, do you have any kind of telehealth agreements with Children's Hospital Seattle, for example? Or do you have transfer guidelines? Do you have any protocols about how to manage agitation in your ED that might be informed from best evidence? So those things were included in the policy statement. We also included a big systems of care consideration, which really pushed on the fact that you need to optimize your resources, you need to improve payment services for mental health. You needed to address the issue of boarding in the emergency department and try your best to find a way to reduce boarding by being really careful about who needs to stay in the hospital, what needs to happen during the hospitalization, what is ultimately their plan for being sent to an inpatient psychiatric facility. And should you have already a pre-existing agreement with some of those inpatient psychiatric services where you pick up the phone, you know who to call. The other thing is that better legislature, better policy, and that has always been at the crux of the problem because finances, more capital, and more better legislature are always at the root of the problem. So we also meant a little policy piece in there that was not previously as strongly addressed. We also included a research element. Again, I'm not going to say a lot about this, but it is very important when you are trying to make a move, when you're trying to move the needle, when you're trying to go to Capitol Hill and argue something, it is really best to come in with a strong preponderance of evidence to show this is best practice, this has been proven through research and evidence-based research, especially the element of equal effect, the issue of equity in mental health. And one other thing that I personally was very passionate about, I strongly believe that the social media has a very powerful negative effect on children and their perceptions. And it is way too easy to put graphic content on social media. And these children who haven't really seen anything all of a sudden face the most vivid depiction, kind of like that a Netflix series, 13 Reasons Why. I don't know if you guys know that or not, but this is basically 13 ways a person tried to commit suicide. And there was a big influx of patients in our emergency department at Harbor UCLA immediately after the full 13 episodes were made available at once. So somebody, I guess, binge watching all 13 episodes. So those things are elements that are also kind of included. Our policy statement and technical report, which was published, got a lot of media attention. A lot of it was really positive, and some of it people took words out of my mouth and used the word emergency room doctors beg for help. I never begged, but I guess that's any kind of attention to the problem that's going to highlight what we're dealing with is good. There's a couple of inappropriate media coverages, but a lot of them were really good. I'm really grateful for being able to bring that problem of pediatric mental health to the forefront and making everybody aware of what currently is happening in our emergency departments. So I think the rest of the time I'm going to talk about what we at the EMS for Children Innovation and Improvement Center have been up to. As it was mentioned earlier, the EMS for Children is a program that is funded by HRSA. It is a basically ongoing, renewable every 4 years. And as part of the EMSC, there's the Innovation and Improvement Center, of which I serve on the executive core. So the structure that we have for developing educational content is, first, within mental health, we wanted to see what are areas of need. So we basically convened a multidisciplinary group of experts that ranged from pediatric psychiatry, clinical psychology, emergency medicine, child life, nursing, rural health, and all the other entities that were involved in the drafting of the HRSA's Critical Crossroad Toolkit that I showed you. And we basically asked them, if you were to pick a couple of topics of highest priority where the greatest gap in knowledge exists, what would you choose? And the two items that scored the highest, number one was suicidality, and number two was managing an agitated child. So we basically took those on as content that we would develop. We have put together basically a 3-part intervention, which included a generation of evidence-based practice. So we had our group in Texas Children's, Dr. Chimpatazi, doing all of the literature review and the research analysis of what is already out there, what areas of need continue to remain in terms of what educational content we should develop for suicide, and same thing for agitation. My site, Harbor UCLA, was involved with developing the content and managing how it's going to get to the end user. And then finally, our other group at Yale, Mark Auerbach, they were in charge of the dissemination of the content, where it's going to go on the website, where it's going to go on our social media presence, and things like that. So the way we did this is we looked at, okay, so what resources are available that we can just share as is? And that was our collation piece. So we collated best practice evidence, like if it was a really good infographic out there, or there was a really nice webinar that we know of that somebody did, or a nice learning module that already existed, we prioritized collating first. Then if there was content that was there but wasn't really pediatric friendly or wasn't really 100% relevant, we tweaked it and we curated it. And that was our second element. And then the third one was, if nothing existed that was useful, especially for pediatric, then we did the creation. We would put this together. We would put it on a part of the website that was our early access program, the KEAP, K-E-A-P. That is the Knowledge Management Early Access Program. And we had roughly 800 reviewers signed up to be reviewers, not all of them for mental health, of course, but we would ask our mental health expert to review the content that we put up on the early access. We received their feedback, and this included a group of 300 people who were not subject matter experts, but they were end users. They were patients, they were family members, they were community ED doctors, they were nurses. they're the ones for whom we develop the content. We ask them to tell us what they thought about how this looked. Does this work for you? Is it too complex? Is it too easy? And once we got all of that feedback, we would improve the content and everything and put in as our pediatric education and advocacy kit called PECC. So PECC is what our end deliverable was going to be. And for example, one of our PECCs was specific on suicide. And this is a QR code that takes you directly to PECC suicide. Of course, we put the entire 104-page document, HRSA Critical Crossroad Toolkit there. But the idea was just in time is not conducive to somebody reading a 104-page PDF. So we wanted bite-sized pieces of information for people to use. So we actually created different kind of elements within that. We basically coordinate them by audiences. As you can see here, it says what's intended for clinicians, nurses, patient family, pre-hospital. And we put on each of the decks the icons for which audiences this was developed. There is this is more pages of what that was. For example, one of the great things that we had was the ABCD of suicide screening infographic that was done by Dr. Joan Asarno at UCLA. She's a child psychologist, and she has a PCORI grant looking at ED-based interventions. We also did podcasts, which were very popular. We did a podcast with Dr. Lisa Horowitz, who was one of the developers of the ASQ screening tool. We basically asked her on a one-on-one conversation, so Lisa, what do you think? What was the purpose of this? How should people use it? And it was really great insight to what the intended use of this suicide screening tool, the ASQ, was. We also put up other suicide screening tools like the Columbia and their safety. And we had another podcast with Dr. Joan Asarno that basically said, okay, so let's say you screened positive for high-risk suicidality. Now what? A lot of the emergency departments wanted to know, what do we do with all these people we screen? So this podcast specifically talks about things you're supposed to do with a patient that's screened positive. And unfortunately, a lot of it has to do with get a pediatric mental health professional to evaluate the patient as soon as possible. But there are other things in there that basically who requires what kind of one-on-one sitting, what sort of reassessments you need to do, what kind of language to use around them, who to have in the room. So it's very great. Every one of these PECCs that we do, we have at least either a bottom line recommendation or an algorithm that basically, if you had nothing else to do with this, only had 2 minutes of time, what is the good quick 2-minute reading? And if you can see here on the right, the suicide risk screening and assessment bottom line recommendation kind of goes with what is a quick read. So we're very happy having those in there. They can be printed as posters and people use them in their EDs. This infographic that was developed by Dr. Asarno, the ABCDs of suicide, very impactful, very brief, and it can be used. You can interpret it very easily and know exactly what you're supposed to do in each of those elements. And the one on the right, this is hopefully going to come out as a publication with ASAP Now Journal this month. We basically looked at, so which patient who is coming in with a mental health complaint, should you worry about that this patient cannot be discharged home? Don't let them go. Keep them in the ED and get them evaluated as soon as possible. Which child can be discharged but needs really close follow-up and they have potential risk? And which child is at low risk, can be followed up with a primary care doctor and a follow-up when available. So we did this as a traffic light, a red, yellow, and green. All of those are going to be on our PECC suicide page. This is again showing you, if you didn't know, this is your screening tools. You can just print them and use them. Some places don't have them integrated into their health record. That is one way that they can do that. And I think I'm going to talk about collaboratives really quickly too, that our collaboratives, one of our collaboratives called the ED Stop Suicide Collaborative. Some of you guys may be part of it already. They were choosing one of the intervention bundles to do a quality improvement in their ED. And one of the bundles was about suicide screening, to implement a suicide screening plan in triage in your ED if you don't already have one. So a lot of people actually, to my surprise, chose the Columbia, which is a little bit more complicated over ASQ, but those are both validated tools that can be used. Also, the good news about our PECCs is that we can see who engaged with it, who used it. I'm sorry, I didn't update this recently. Last update was when I gave this talk a couple of months ago. But for example, in the month of August, we had about 1,700 total page views of just the PECC for are suicide. Of those, the suicide screening tool was the first one, most visualized, and then the Columbia screening was the second one, and the ASQ was the third one. So you can see those easy one-pagers are much more likely to be interacted with than, let's say, our interactive learning module, which we created, is about 30 minutes long. It's really great, but it's time-consuming, and you want to be there. So as you can see, that's not made it into our top list. We did the same thing for agitation. So one of the big elements of agitation was that we did not know that there is not a ton out there on how to manage pediatric agitation without medication. So that behavioral modification, that behavioral de-escalation was not there. So we have actually developed de-escalation tips. We created a learning module that talks about de-escalation, and to the right, you can see here is our algorithm for care of the agitated patient. So instead of bottom line recommendation here, we did the algorithm. Again, one page can be printed, big size like a poster. And as you can see, the very top of it, the purple area, is the verbal de-escalation that we're basically recommending you start with those first before you get into medication or other forms of restraint. We do know from the literature that roughly 80 to 90% of these children who are agitated can be de-escalated without the need for any kind of restraint. So I want to take 1 second here and ask you, if you have your phone, do you mind try to scan this QR code for me and tell me where it goes? Excellent. All right, so it should go to this page here. It should go to this page that you see on the right here. So those are our verbal de-escalation tips. And very straightforward. It's managing the environment, use behavioral de-escalation, and use calming interventions. And that's something that you can easily rehearse, practice case-by-case basis. And there's actually the learning module that actually has a case that goes with that you can use to practice each one of these strategies. This was really one of the top items that we got a lot of requests for, because there isn't really anything like that for pediatrics. So it's great to know that this is now available to everybody, and our graphic designer did such a good job making it really easy to follow. But I have to be obligated to tell you that at some point, verbal de-escalation doesn't work, and we have to actually use medication. So Evidence Synthesis Center at Baylor, developed a library-initiated search system to look at all the possible medications that have had sufficient high-grade evidence to support their use. So there's some medication that we use, and some of you may use in your emergency department, but they're not really supported by the high-grade evidence that's a strongly recommend, for example. And we decided not to suggest one medication or another, because we realized a lot of hospitals don't carry everything, but many hospitals have at least one or two of these. So we figured as any of these would be fine to use, but if you use one of them, look in the considerations piece and see, okay, for example, if I use diphenhydramine, when can I not use it? What side effects it's going to have? And we thought that this was actually, it was feedback from our community EDs that they really liked how everything was simply put together next to each other. Doses were clear, timing was clear. So we're very proud of this one too, actually. This is a really great one. You can just basically print out also as a poster and have as your medication list, again, with no one specific medication given as a must do. We do use olanzapine quite a bit. We like olanzapine. Also, being in a county hospital, being old school, chlorpromazine is used quite often. But I do know that one of the things that we know is for neurodivergent children, chlorpromazine happens to be very effective. So that is actually one of the ones that is considered specifically for neurodivergent children. And I wanted to say that one thing here, I don't know if I showed this. Yeah, so here, if you can see EISC agitation in neurodivergent patients with Dr. Alice Kuo and Eileen Claudius. So Dr. Eileen Claudius is a very nationally known adult and pediatric podcaster. She does a great deal of work for MRAP. She did a podcast for us with Dr. Kuo, and Dr. Alice Kuo is a national expert in neurodivergent children, has federal funding for that. So Dr. Kuo was the one that's saying that she uses chlorpromazine for her autistic children in her clinic, and that for that indication, it is more often used than for neurotypical children. So that one is one little asterisk I would put there, that it is more beneficial to neurodivergent children. And then I just want to give you an update of where we are, because we constantly are adding content and these areas are going to continue to develop. So our learning module, our interactive learning module with a great emphasis on behavioral de-escalation, actually has a video segments that we actually professionally shot at Yale with a professional 14-year-old actor who knows how to get agitated very well and is a real professional actor when it comes to de-escalation. So if you get a chance to go see it, that's a really great interactive module that has the verbal de-escalation techniques one by one in there. There's also a pre-hospital companion to that we're trying to develop, realizing that our pre-hospital folks have access to different kinds of medications than what we use in the ED. So that is another one that is in development. We are working with our pre-hospital domain of the EISC. That's taking a little bit longer. As you know, every time you're collaborating with another group, both group needs to be happy with it, so it's taking a little bit longer. And the other one being the suicide hospital-based one, and that, again, because we have so many subject matter experts on the suicide one, that is also taking a little bit longer. And I just wanted to mention that some of these algorithms and bottom line recommendations we do in conjunction with our Canadian partners, with the truck. So our timelines are sometimes have to be aligned with their timeline. So the agitation one is already available, and I showed that to you. The next one coming out that's related to this is going to be child abuse. So we just started launching a PECC for child abuse, and not all the elements of PECC are there, but if you go to the PECC page based on these, if you go to the either the QR code I put there or this link that I put there, you can get to the main PECC page, and then you can see what we already have available for child abuse. That's another popular one that a lot of people were looking for, that piece by piece is coming in. In terms of engagement data with our PECC agitation, as you can see, we have over 1,000 hits for that. The podcast series, we got 98, 371 for our non-pharmacologic, that the one that I showed you, the QR code that goes to the verbal de-escalation tips. So that was also very well received. Interactive learning module, as of beginning of October, we only had just launched it, so at 14 visits. I think when you guys get a chance to go there, and there's 218 people here, then our numbers will go up on the learning module there too. So I'm excited about that possibility. So please go and check these out. So last part is going to be talking a little bit about this QI collaboratives. I think you are already familiar with these, but we just had a 9-month collaborative called ED Stop Suicide, Emergency Department Screening and Treatment Options for Pediatric Suicide. There's a cohort of about 85 teams. It started in February. It just wrapped up. We did our last meeting a couple of weeks ago, and a great number of teams stayed all the way to the end and accomplished their QI initiative. They were asked to work on one of 4 bundles, either suicide screening or assessment of somebody who screened positive for suicidality. A group that worked on ED-based intervention. I think the largest group we had was on ED-safe planning, things like lethal means restrictions and things like that. So that was really great. And this is a map of the states that participated in this. The ones in the dark blue are also the Pediatric Mental Health Care Access Group that participated in the program as well. And I think Delaware was the only state that had only the PMHCA participate. But a lot of these sites had their pediatric emergency care coordinators and their shared partnership programs involved, which was really, really great. I honestly feel that collaboratives are one of the best ways that we can get the education into the community, and the smaller critical access rural hospitals really work together, learn from each other. And I just thought this is such a wonderful opportunity. So very proud to have been part of these collaboratives. And this is basically a narrow down of where these collaborative hospitals were like. If you were looking at the very last one, this is based on your pediatric volumes. As you can see, we have a mix and match of different pediatric volumes. About a quarter of the hospitals were hospitals that saw less than 15 pediatric patients a day. If you look at service area, about a third of them were rural hospitals. If you look at ED configurations, the majority of them were not children's hospital EDs. Exactly what I want. I don't want children's hospital EDs to be the participants. I want the ones who don't have access to children's hospital EDs to participate. So very lucky to see this. And 52 of the 84 teams that participated have a pediatric emergency care coordinator. And I don't have to preach to you guys, you know that having a PECC really increases your chance of having better adherence to guidelines, have better pediatric outcomes, and having this pediatric readiness element is now being included, thanks to Dr. Marianne Gashi-Hill, into the American Board of Emergency Medicine certification program. So all of the trainees are required to participate in activities related to pediatric readiness, which is fantastic. And this is basically a final check that 52 of the 78 of the hospitals, actually I guess 78 ended up staying. So 52 of them completed the check-in survey, and this was the distribution of what of the bundles they selected, and 100% of them identified a strategy, but because it was such a short collaborative, the majority of them have not been able to yet demonstrate the improvement because they just implemented it. So we're hoping to go back to them in a period of time to see what proportion of them actually have improvement that's stuck. So this is going to be a follow-up piece to that ED stuff. And then this is our group of PMHCAs. This group is basically those who work with integrating behavioral health, pediatric mental health into primary care and supporting telehealth access programs to enhance the reach of the general pediatric practices. And this is all the states that they're coming from. You can see pretty well representation. I think 45 of the states are included in that. The second of the collaboratives is the Pediatric Readiness Quality Collaborative 2.0. Some of you guys may have participated in the first one, which was 2018. They looked at, interestingly, weight in kilogram was one of the items that a lot of the collaborators worked on. It was surprising to me that many places were still not doing weight in kilos, but it is a big thing. And because of the collaborative, a lot of the sites switched to weight in kilos. That is really important when it comes to drug dosing and medication errors. And then there was also the patient safety assessment, reassessment. The first one had a bundle in it that was doing a way to display abnormal vital signs. And I remember my hospital, Harbor UCLA, was part of this 5 years ago. And what we did is on the tracking board, if your heart rate or your blood pressure or your temperature was above the 90th percentile for what's considered the institutional normal, then that number would display with a yellow highlight. If it was in the 95th percentile, it would display with a highlight of red. So you can walk from like several feet away and you can catch these reds and yellows and say, oh my God, what is red here? And that was one of those interventions. But this time we have patient safety, assessment, reassessment, pain management, and suicide. So suicide is one of those things that a lot of the participants from the PRQs, from the ED Stop Suicide, decided to also join this collaborative because the ED Stop Suicide was more qualitative. Basically, the outcome would be X number of hospitals demonstrated, quality improvement in area A. But this one actually says how many patients were screened for suicide. So this is more of a robust data collection. So a lot of the hospitals wanted to get patient level and institution level data. So that was a great draw for people to participate in the PRQC. That one is going, just started June 2023. It's gonna run for 18 months. So it's going to go through December 2024. And the goal is to have 100% of those sites have provided a quality improvement initiative in one of those areas by December 2024. And everything related to the collaboratives is also on our EISC website. So this shows you the number of page views. So far, for example, for the PRQC, now almost 6,000 page views of 503 unique visitors, just looking into what the collaboratives is about. So as the collaborative completes and we have more items popped in there, be more market around this, there's going to be more visibility around it. So we really like the idea of having an enduring home for some of the work that we're doing in these collaboratives, being the EISC website. As far as the work ahead, I kind of feel like, again, I'm preaching to the choir. You guys all know the work ahead better than I do. So we want to make sure that this work is not done in silos. HRSA has many other assets, including the Pediatric Pandemic Network and some of the regional works like the Western Regional Alliance for Emergency Medicine, RAPAM, or the Region 5 for Kids in your area. There's the Gulf 7. And they should all be working together with the EISC to develop these resources and share whatever we develop. The other thing which is very near and dear to me, I'm also part of the PPN, so I really would love to develop some resources for children who are in schools and community. I think mental health, a lot of it is during school. Children spend a lot of their time in school, and just from my own school system, I kind of feel like the schools aren't really as in tune with children bullying and those who are bullied and mental health things. They need to be a little more vigilant, and I hope to be able to build more resources for the schools and the communities. That's an area of, for me, a big gap right now. We also wanted to have, just like the American Board of Emergency Medicine is doing and American Academy of Pediatrics is doing, we need to train the future healthcare professionals to better understand the needs related to mental behavioral health. We also, as I mentioned, I can't say enough about how much disparities we have in this space and how important it is for us to identify and recognize that certain groups are disproportionately affected and that we actually need to advocate very strongly about equality and justice for them. These QI collaboratives, my personal opinion, I love these collaboratives. I hope we do more of them. I kind of feel like this is the best way to get people to engage, to talk, to share their work. I just love being in those coaching sessions and have a tiny little hospital in Virginia give me a video tour of their ED. And hey, look, there's only 3 of us. This is where our shelves are. This is where this folder goes. It gives you so much insight into what limitation and resources they have. And it allows me to help you knowing what it is. I can put myself in your shoes rather than trying to make a blanket statement. You guys should be doing this. Starting Monday morning, everybody should be doing that. This is a much better way to do things, be more collaborative, make people feel like they're part of this, they're contributing. And, the last part is obviously a culmination of everything, optimized data on disparity and progress in showing adoption of best practices and better mental health outcome for children. And just to conclude, this is a problem. I'm calling it crisis proportion. I don't want to say it's a problem, but it's a preventable crisis. We can do a lot to slow this down, and by better understanding early on when trouble is kind of brewing, we need to do better with families and parents and schools, and to make sure that we provide the most optimal environment to be able to manage this. The EDs are unfortunately safety nets. There's not much we can do at the moment. We can't say no, and we can't push them elsewhere, but it would be nice for us to do more prevention so less of these end up in the ED. I shared with you what EMS for Children has been doing. We are currently in the midst of year 4 of a 5-year grant. So we have a year and some months more to go to do more of this work. Hopefully we get renewed. We would love for participation from any of you guys. There is a get involved button over at the EISC website. Please go ahead, and we would love to have your participation in any way you like. This is meant for you and making your lives easy as you care for children. And the joint statement, again, hard labor from a lot of us. Please, when you get a chance, go and read it. My email is in there. If you want to send me a critique or something on the policy statement, feel free to do. I've received hundreds of them so far, some good, some bad, but I'm happy to address that. And if you need to reach me for anything, this is my email, and I'm happy to answer any questions or anything you want to share with me by email.
Hey, Doc, we do have a question. Are there any established processes for pediatric mental health patients that board in an ED for multiple days? Best practices for providing psychiatric support while waiting for placement?
Yeah, this is one of those sore subjects for us because We are, as emergency department, we're not very good with those that are ward patient type. When a patient boards for several days, we in the ER are used to coming in, diagnosing the problem, doing tests, figuring out what it is, admitting, discharging. But when patient comes in that is boarding, the couple of things we can do. Number one is we need to make sure we understand that this child is in a room with no walls, has no entertainment, no food. So we need to make sure that their hygiene, their food, their ambient environment, their ability to go walk around, games, things like that is there. So we treat them as somebody who actually needs to spend their day rather than forget about them because we're so busy. We don't know how fast time goes by. That's number one. Number two is that we have a process where twice a day, once in the morning, once in the afternoon, a pediatric psychiatrist comes in and do an assessment to determine the appropriateness of the continued need for boarding. And a lot of times our child psych says, you know what, they don't need to board anymore. I think we got collaterals, we got a contract, they have a follow-up. I just talked to their psychiatrist and they can go. But that's rare. You know, we talked about how shortage area of psychiatrists is affecting everybody. So that's another thing is frequent assessments. We also need to make sure we have a sense of when something is about to escalate, when the child is starting to complain about something, they say they're cold, they're hungry, we need to address those. It's not a whole lot more when it comes to a boarding patient. All we can do is keep saying, is this patient still needing to board? We need to realize that a patient who is boarding might end up having a change in their mental behavioral health status, meaning they can get escalated more or they can get better. So this frequent reassessment, which I can't do as an ER physician, I actually need my mental health professionals to do this for me. So those are some of the major ways to deal with this. The boarding is a whole, different process. So for example, what we say to community EDs, if you know you have a boarding child, if possible, try to put them in a private room away from the rest of the flow of the ED and be in a position where if you need to act on it, it's not going to disrupt the rest of the ED. Because if an agitated child is in the middle of the ED rooms, it's going to affect your entire ER and everybody else, and the parents are going to complain and what have you. The second thing is if you have a child that's boarding for mental health, and if you're in a general ED, keep them away from where the adult rooms are, especially those who have adults in them who are basically there for intoxication and things like that. You need to keep this child safe. Having said that, a lot of these things are easier said than done. Some of these hospitals that I go visit, they just really don't have a whole lot of resources, and it's really, really tough for them to board. There are a couple of hospitals that have this intermediate care area, at least I've seen this 3 times, is a place you go sort of in anticipation for being admitted. So you have a separate team taking care of that. If you have that, then you move this patient away from the ED. I have to say, I am very lucky at Harbor UCLA. We actually have an adolescent psych ED, which I didn't want to say, but I want to tell you. It has 10 bedrooms. It's very awesome because all we did is take a separate area of the hospital. We knocked out the walls and made 10 little rooms. And that is about 100 feet away from the main emergency department entrance. So when a patient comes to the ED, I or one of my residents who is senior resident, has to be senior resident, goes in and do what we call a medical screening exam. If we determine that there's nothing psychiatric going on, then the patient gets directly sent over to adolescent psych. And we found that to be a much better environment for boarding. And somehow miraculously, because the patients are in front of the psychiatrist the whole time, somehow the collaterals happen faster, dispo planning is faster, they get to send home. So we actually just got this paper accepted. Hopefully it'll be published in a couple of months. We can share the experience of what we did and how it worked. But it really made a huge difference in our ED throughput, and it made a huge difference in the throughput of those patients by just having them be treated in a separate psychiatric area. But not everybody can afford that. So that's the downside of that. Sorry, that was a long answer to your question. I hope that answered what you're asking.
I'm not seeing any more questions thus far, but we can certainly forward them your way for inclusion with the post-symposium packet.
Yeah, thank you so much. I know it's late for you guys, and I totally understand. But like I said, I just want to make sure you felt comfortable to just reach out, ask any questions anytime you want. I left my email address, and you guys have my slide deck. So if you wanted to share it with everybody, I'm happy to have that done.